say that I'm a Ooh, okay. Hello again for those online. I'm those watching this recorded later. I'm Spencer McClelland. I'm a general obstetrician gynecologist. I work at Denver Health, where I have a few different roles, but one of them is as the Associate Director for Outpatient Services for the Division of OBGYN. And then I also have the privilege of working with CPCQC on the SOAR initiative as one of the co-chairs for the steering committee, which means that I every now and then say something somewhat insightful that helps the program, but most of the work is done by Amber and Sydney and Katie and the wonderful team. And I think it's important to know that I've spent 2.5 years at Denver Health, which, as many of you know, is a academic, public, high-volume hospital that serves as the safety net for the city and county of Denver. And prior to that, I spent 5 years in private practice in New York in your very prototypical urban, bougie, small, busy private practice, where over the course of 5 years, I did about 800 deliveries personally, spent many, many hours in the hospital at night, pushing with my patients and incredibly hands-on. And I think there's a fine line between just sort of like giving your credentials and self-aggrandizement. But as we're here today talking about NTSV cesarean rates, my personal rate when I was in practice in New York was 11%. And happy to say that since joining Denver Health and having our data made transparent, I know that my net rate is now 16%. So on that note, I'm going to launch into our talk itself. So this talk, but I got to click the thing. I might need some help because it's sort of pretending like it's still in Zoom mode and not like it's in. Oh, no, it got worse. The handheld clicker we can try, but I think it's not actually on the. You got it, Sydney? Yeah. Thank you.
Yeah.
Zoom people, can you hear me? I don't know what you would. Tina, can you still hear
Yes,
us?
yes, I can hear you, Spencer.
Great. Hi, Tina. Okay, we good? Should I be able to right and left now? All right. So this topic's entitled Follow the Money, about financial incentives and how they affect C-section rates. Follow the Money is a misleading title. Some of you may have panicked and worried that this was going to be about how to milk every single dollar out of your delivery hospitalizations. This is quite the opposite. For those of you who were alive when Watergate happened or were raised by Watergate-era parents like I was, you know that Follow the Money is a call to arms to trace the impact of money on corruption. And so we use that in this sense to talk about how financial incentives influence behaviors and how we might be able to use money in a positive way to influence behaviors to reduce C-section rates. In terms of financial disclosures, we have none, but both Matt and I abhor non-indicated C-sections and lose sleep over their existence. So if you do hear us being anything other than delicate on that topic, just please know that that's because it comes from a good place. And in terms of goals, first of all, is to appreciate that this is a talk about behavior. This will be about dollars and cents to some degree, but the two parts of this talk are about how money and other things influence behavior and decision-making. And so you need to understand that there are various implicit incentives that drive obstetric behavior, and that there are also explicit incentives that we're going to design aimed at improving obstetric care, including C-section rates. And that is, as a disclaimer, much like Amber talked about earlier today, in recognition of the diversity of gender identities of birthing people in the state of Colorado, we will be using gender-neutral language. There may be moments that non-gender neutral language slips through, and we do not mean that as disrespect. Similarly, we don't mean as disrespect that we're going to be talking a lot about obstetricians or other physicians in this, and not so much about other birth providers or birth attendants. And that's because obstetricians are the problem. I'll just say that, right? We're the people who are deciding to do C-sections. And yes, we are in a team that is maybe deciding that, but it's not meant to ignore other people when I just talk about doctors a lot. And the last is that this content may seem cynical, but it's not meant to land you in a despondent place at the end of this talk. It is meant to look at the hard behaviors that we have, and that requires hard looks. So without further ado, we're going to start with Ivan Pavlov, who I'm sure you all recognized immediately as soon as he popped up on the screen, particularly because there's a dog next to him. I discovered through debates with my daughter that I am an elder millennial, although she disagrees. So it pains me to use a Twitter quote, but I love this quote, which is, out of nowhere, my nephew just asked, do you think Pavlov thought about feeding his dog every time he heard a bell ring? And now I'm going to be haunted by this question. The millennial move would have been to show you a clip of Eddie Izzard's bit on Pavlov's dog, but that's too long to show for today. So look it up afterwards. So I'm going to argue today that humans are, like any other animal, prone to conditioning. And we're going to consider three things in terms of how we're prone to conditioning. One is that we're risk averse. The other is that we have basic needs that drive us. And the other is that we respond to bribery. And I mean that in both financial and non-financial senses. You all probably are familiar with the idea of Maslow's hierarchy of needs. Interestingly, I heard recently he did not intend this as a hierarchy. Someone just sort of diagrammed it as such and it stuck. But it is this idea that there are sort of more base needs, the physiological and kind of rudimentary survival needs, and then loftier and loftier needs as we go up. And in a similar sense, I'm going to argue that the obstetrician, which I've called Homo obstetricus, has a hierarchy of needs. And so for each of those three things that I said are true of animals, they are true of an obstetrician practicing on a labor floor. We are risk averse, and therefore we have a cognitive bias against risk. We have basic needs, and so we have this pressure at many moments in our time spent on the labor floor of those competing needs influencing our decision-making. And lastly, of course, responding to bribery. That'll get us to our financial incentives. So Neil Shah was our keynote speaker, and as it just so happens, one of the most impactful ideas that I ever heard was the idea he touched on this morning about how it's never wrong to do a C-section. He said there's no counterfactual, right? And I'm going to walk through this again. I first heard this when I was a resident at a conference in 2016 where he presented, and it's stuck with me ever since. And he gave me permission to reproduce it here today. So the first is that if you do a vaginal delivery and the baby comes out healthy, great work, you made the right decision. And then as he pointed out, if you do a C-section and the baby comes out healthy, well, thank goodness that C-section seems to have made the baby healthy, right? We intervene at a moment where the baby is now healthy. But weirdly, if you do a C-section and the baby is born unhealthy, thank God you did that C-section, right? Because imagine how much worse things could have been if you had hung in there longer. And only when you do a vaginal delivery and the baby is born unhealthy have you seemed to make the wrong decision. So there's this imbalance in how we make our decisions that seems to push us towards C-sections as just being righter and truer at any given moment. Not surprisingly, I don't have a number of studies to throw up here because there's just way too many of them. But this manifests in how the concept of risk and the concept of medical legal liability change C-section rates. So if you look region to region and you look at any of the following things, whether it's payouts to litigants, malpractice premiums, malpractice insurance premiums, the presence or absence of tort reform in a state, they're limiting liability payouts. Each of those things will influence the C-section rate in very obvious ways, region to region. So should it be any surprise that obstetricians behave based on our perception of risk and liability? No. This is one of my favorite, and just to keep the CPCQC kind of all-stars of the past 12 months going, this is a study by Stephen Clark and his colleagues. He was our webinar presenter in the fall, a very fun webinar. And this is about temporal patterns of childbirth. And they looked at many different things, but one of the things they looked at was, is there a difference in the frequency at which C-sections occur based on the time of day? And just to break down this graph for you, the bottom two lines, the purple and the blue, are Saturday and Sunday. Everything else is a weekday. And you'll see that there's 3 spikes throughout the day, kind of roughly correlating to breakfast, lunch, and dinner, at which primary C-sections occur. Now, those of you who instantly want to combat data shown to you will probably point out there are scheduled C-sections that influence this. That's to be sure. The authors argue that's not the entirety of the effect seen here. And so the thing you have to wonder is, what would make someone more likely to do a C-section at 7 in the morning? I might say trying to get back to their office if they're in individual or a small group practice because they have patients to see. Similarly, at the end of the day, and Elizabeth McDaniel from Vail kind of pointed this is like, if you're specialing your patient, or what I've seen a lot is if you're in a group practice and you just don't want to hand a C-section off to your partner coming on at night because you just don't want that judgment from them, you'll kind of crystal ball it and go, you know what, 2 hours from now, same situation, still going to be arrested. I'm going to do this now and we'll save that evening C-section for my partner to have to come in. Lunch, though, I don't know if any of you have seen that like really fun study about how prison sentences are harsher right before lunch, if handed down right before lunch, and are more lenient if handed down after lunch. Now, there's interesting pushback to the data in that study, but it's the idea that even things as simple as like having your stomach growling might make you less lenient in your decision-making. This is worth thinking about because, again, we have a lot of different hospitals represented here with a lot of different practice models. But if you're looking at practices where people don't have to spend their entire time in the hospital, so anything other than a laborist or hospitalist model, I guarantee there will be something other than the needs of the patient influencing thoughts about how long you're staying in the hospital. So now we get to money. Does money affect behavior? The answer is, of course, yes, but not necessarily in straightforward and predictable ways. And we're going to talk through what that means. So there are direct effects. Those direct effects would be the thing that you expect to happen or intend to happen when you link money to a behavior. And then there are indirect effects where it's something other than you anticipated, something you couldn't anticipate. And very often, indirect effects are actually paradoxical to the intended direct effect. Now to the rub of this talk today. Does money affect obstetric behavior? And the answer is also, of course. Just want to make sure everyone here knows that physicians and hospitals receive higher reimbursement for C-sections compared to vaginal deliveries. And if you look at this graph, this is one of many sources you could pull from, but this is aggregate data that is looking at the composite reimbursement for a standard cesarean birth. I don't know what standard means, but standard cesarean birth versus an uncomplicated vaginal birth, and it's $20,000 more. Now, if you ask people why the system was designed this way, the people who believe in this differential will say it's justified, and it's justified because there's expertise involved in doing a C-section, not that there isn't expertise in managing labor, that there are costs of an operating room, that there are costs of a longer hospitalization. And so people just have come to accept the fact that, yeah, it just costs more to do a C-section, so we should therefore reimburse people more to do a C-section. That's the direct effect. And the direct effect that people point to is also that they want to make sure that you're valuing C-sections, right? Because God forbid we didn't pay enough to have them done, and then people avoided doing them when they were necessary, right? So that's the boogeyman that people immediately invoke when talking about this, is the idea that if you pay people less, well, then they're going to be less inclined to do them and more harm will come to patients. The indirect effect is the question of whether this might incentivize doing a C-section. And on our webinar in the fall, just to call out how that went, I did ask the question because Stephen Clark did a great job talking about what he called market forces, just the massive forces like medical legal liability, pressure of a busy labor floor, those things that tend to push towards a C-section. And I said, I didn't see reimbursement on here, or the differential reimbursement. And his response was, I think verbatim, I've never seen anyone say they were going to do a C-section because they were going to get paid more for it. That's probably a true statement, right? No one, as they walk into the operating room, says, this feels like a great decision because I'm going to get more money for it. But the idea that nobody's thinking about that, or that even what I'm going to argue unconsciously that affects behavior, is, I think, not one we should dismiss out of hand. So the next two slides are really the linchpin of this. So what happens when the price goes up and what happens when the price goes down? By price goes up, I mean the differential between reimbursement for a C-section and reimbursement for a vaginal delivery. So this is a fun study that looked at differentials in Medicaid reimbursement for cesarean delivery versus vaginal delivery. It compared 9 different states over the course of 4 years. And it found what's called in economics terms, a positive effect on treatment intensity. That means the frequency with which a C-section was applied as an intervention. And they quantified it as, for every $100 increase in the differential, the C-section rate increased by 0.7%. That seems like a compelling fact to me. So what happens when the price goes down? And again, this was not consciously done, but Neil Shah is one of the co-authors on this paper. It's just a great study. This was a retrospective examination of a blended payment model. So this is like a key idea. Blended payment models mean that you have found a price, a reimbursement value in between what you pay for a C-section, what you pay for vaginal delivery, and that's the single thing you give people for a birth. And you don't break it down by what type of birth was had. And so in most blended payment models, which are also called alternative payment models, that's somewhere in between the price, the reimbursement of a C-section and the reimbursement of vaginal delivery, the dollar value that they set. So this is from the state of Minnesota, where they trialed a blended payment model. And they compared that state to 6 control states, just meaning 6 states that did not adopt an alternative for a blended payment model. And they saw, not surprisingly, since I've been invoking it in this talk, that the model mitigated against the use of cesarean delivery, meaning that for every quarter of a year that this was in effect, the C-section rate went down by 0.27% for a total of 3.24% decrease over the course of the time it was in effect. They did include balancing measures. That's a term that some of you may be familiar with. That's the idea that any time that you're changing something, particularly something that is may affect a health outcome, you want to make sure that changing that thing doesn't cause an adverse effect somehow else. So common balancing measures when talking about C-section reduction are NICU admission, maternal hemorrhage, those kinds of things. And they, not surprisingly, found people don't come to more harm by doing fewer C-sections, right? Because we've always talked about in these talks, there's an abundance of non-indicated C-sections. The indicated ones clearly save lives. Now, I did say that was an effect seen over the course of that this was an effect. You may say, why did it stop being an effect? And interestingly, it was rescinded after 6 years out of concerns for insufficient valuation of cesarean delivery. Now, this is really hilarious in a sort of gallows humor way to me, because this is the kind of thing that someone would throw up as a roadblock when trying to implement this in the first place. The idea, getting back to that direct effect logic, that C-sections are justified as being more expensive because of all those reasons that I listed. They had already gotten past that conversation, gotten to the blended payment model, yet someone seeing the positive effect was still persuasive enough arguing that this was an unjust way to value the work of C-sections compared to the work of vaginal births, but they managed to torpedo the program, and it's no longer in effect. So I'll just say this another way. The higher the differential between a C-section and vaginal birth reimbursement, the higher the C-section rate. And when those differentials narrow, C-section rates go down. Now, why would this be a case? Let's get back to the same terms we're getting used to, which is direct effect versus indirect effect. Now, if it's direct effect, that means like this is what it's meant to do is you pay someone more so they do the thing, right? So if someone was really just money grubbing, I don't know another way to say it, then they would go, oh, hooray, I love getting paid more for the work that I do, so I'm going to do as many of these as possible. There may be actually some people out there who operate this way. That's probably not the main effect, right? Because you just hope that your leadership and the physicians you're working with have a better moral compass than that. In terms of indirect effect, this is, I think, where it gets to the question of how much do the things that we are dealing with as other influences push us towards C-section, and therefore how much does the differential reimbursement do to work against that, or just to allow us to kind of slip down that slippery slope? So one thing I'll point to for hospitals is this question of a culture of safety. This is a bit of my personal bias, but I do think, and it might be a hard study to do because there'd be so many forces pitted against a study like this, that depending on what a hospital defines as safety, the more they work on that, the more C-sections you'll do. For a lot of hospitals, I think safety equates to avoiding lawsuits. Avoiding lawsuits often equates to avoiding bad fetal outcomes. And so the best way to avoid a bad baby, as we showed from that 2x2 risk rubric from Neil Shaw, is do a C-section. I worked at a hospital in New York that had a safety officer program. I don't know how many of your hospitals have that, or if you're familiar with the term. That's an extra non-direct care person whose job is to, I'll try to say this in kind ways, mill about the labor floor and participate, read that as interfere, in the care of a provider and their patient. My experience of this as a well-meaning obstetrician was usually somebody who walked into the room and goes, I'm concerned about this patient. Let's talk about doing a C-section. And I had to go out into the hallway and argue why the tracing had reassuring features or why the labor course was not protracted. that wears you down after a while. The other thing I'd say for hospitals is busy labor force. So everyone here is experiencing what it's like to have a limited number of rooms, limited number of nurses, and has probably been subject to a conversation where somebody has asked what's happening with your patient in that room while there's a bunch of patients sitting in triage waiting to get their induction started or needing to start MAG. And that obviously puts pressure on people. If the system didn't reward the hospital for doing C-sections as a way to terminate labor management early, those would be very different conversations that we were having. The last thing I'll point to is opportunity costs. And this comes back to physicians having basic needs, was what I said. So every moment someone in a kind of mixed office to hospital practice, as opposed to laborers practice, spends in the hospital comes at the expense of something else. That could be time sleeping in your own bed. That could be time spent with your family. That could be an obligation you had one evening. Those are all sort of non-monetary opportunity costs. And then there are actually legitimate monetary opportunity costs. If you're in solo practice and you're managing a labor for the entirety of a workday, every single billable visit that you had scheduled that day is gone. And not surprisingly, in my experience, the people who had that model were the people most likely to kind of get out of there early when someone looked like they were arrested or had the lowest thresholds, lowest tolerance, I should say, for fetal heart tracings. So coming back to, I'll put this all together, it all goes back to the fact that we're human, right? So we can all say that we know vaginal deliveries are better for the patient in the vast majority of circumstances. But when faced with concerns about risk and medical legal liability, it's easy to give in. When faced with a long labor and sleepless nights and missed office visits and time away from family, labor management seems like a losing investment. And I do use that word investment on purpose. And when you couple that with the knowledge, however implicit that knowledge may be, that C-sections earn more money, how strong can we expect people to be? So this is a theme of this year's conference, because last year we focused a lot on the individual provider level kind of coaching. And this gets back to what Neil Shah said. What was the way he put it this morning? The one we put on Instagram? This is my own version of it. A bad system will beat a good person at every time. And this is my version of it. In the war against, it's wordier, not surprisingly. In the war against non-indicated C-sections, there's only so much that well-intended foot soldiers can accomplish when faced with forces beyond their control, especially when those forces condition us to behave a certain way. So I'm going to hand it over to Matt now with this comment. We've been talking a lot about the implicit incentives that are built into the system, the way that money causes us to behave a certain way that's not necessarily called out. And in order to counteract that, you need beneficial explicit incentives. The word incentives fell off there on the slide. So now Matt is going to take over and talk about those explicit incentives.
Powerful stuff. Just to let you all know, my name is Matt Haynes. I'm the Special Finance Projects Manager at the Department of Healthcare Policy and Financing. So I'm not a clinician or an obstetrician, but I have a really cool job. I've been with the state for 15 years now. My job was first to bring as many federal dollars into the state of Colorado for Medicaid as possible. We were a tax deficit state, so we paid more in federal tax dollars than came in. So my job was, how do we bring it all in and pay for Medicaid? About 8 years ago, my job shifted in a very meaningful way. We had already brought the dump trucks full of money. Now I got the cool job of, how can we use these dollars to drive quality, to drive best practice, to drive innovation? I'm going to touch on a lot of the things that are principles that drive the work that I do and that we've done with the program I'm going to talk about, and make sure I know what I need to click here. There we go. The Hospital Quality Incentive Payment Program. What's really driving us in the decisions that we're making around that? I also have to get a little nerdy with you, because this is a technical payment program around hospital reimbursement. Do folks understand, you know, in the state of Colorado, we have what's called a fee-for-service state, or a managed fee-for-service state for Medicaid. So we pay for the number of services that you do with a certain amount per service. We're not a managed care state on Medicaid. We have some limited managed care. Unbeknownst to many people, we also have things called supplemental payments. These are payments that are outside of the claims-based reimbursement system. It basically looks at what is Medicaid spending on a particular amount of services for a particular provider type. What would Medicare allow you to pay? And is there a gap? And if there's a gap there, then you have some freedom to do things with those other payments. That's where my job gets cool. Because while we're paying for fee for service, I have this bucket of dollars that is like you're paying them more and more. We are. But these are dollars that we're not having to tie to, you did this service, I'm paying you this much. We get to get creative. And so we're going to talk about one place we're doing that, particularly around these populations in the Hospital Quality Incentive Payment Program. Because while doctors are human, hospitals as organizations are not. Right? That's artificial intelligence, essentially. It has one purpose in many cases, is revenue maximization, often hidden within risk aversion and safety. So what have we done? What is the opportunity we have with the Hospital Quality Incentive Payment Program? We actually have 3 groups of measures within this payment. We have patient experience, patient safety, but this is where we are really focused in on maternal health and perinatal care measures for hospitals. We focused here, this is like, what can you do within the 4 walls of your hospital to impact this patient population? We're going to talk C-sections today, but I want you to see kind of the suite of measures we're talking about. Some of those balancing things that we were just talking about. So we're doing a good job of exclusive breastfeeding in the state of Colorado. We were pushing some baby-friendly initiatives early on with this program. We just track this now to make sure we're still doing a good job. C-section, we're going to talk about, again, NTSVs is what we're looking at here. But you see some of these other balancing pieces we have. We want to make sure hospitals are putting in systems to screen for perinatal depression and anxiety. Maternal emergencies and preparedness. This is really a process measure. And these are all built on AIM bundles around structure and process measures to make sure you're addressing maternal emergencies. We're also going to tracking cases of severe maternal morbidity as well. We're pulling the claims data to see how folks are stacking up. We also had a reproductive life family planning measure in place that hospitals had programs in place to actually talk to women about their reproductive life and family planning decisions. I won't put a value statement on this next comment, but we met some resistance around that particular measure. I started really hard in negotiations on this one. I'll give you a little bit of history. I was going to say everyone should be offered long-acting reversible contraception immediate postpartum. You could imagine some of the pushback we received around that. It ended up with this measure. What we're kind of getting is not really meeting what we thought we were going to get in some cases. And with recent Supreme Court decisions and other religious affiliations, that's made it difficult for us. So this will be changing. We're going to be changing this, working with CPCQC and the Maternal Health Task Force at CDPHE to put in a postpartum discharge planning bundle. So a lot of cool stuff, but let's get to the meat of why we're here. Let's get wonky, and then we'll talk about more of the other side of this stuff. So we have built a measure that says you can earn the points here, points in this program equal dollars. There's money. So on the one side, what Dr. McClellan is talking about, reimbursement for a procedure to a clinician or an obstetrician, I'm now talking about reimbursement to an organization. That we know that when quality directors and clinicians got into the work of healthcare, they got into the work to help people. We also know that organizations are revenue maximization organizations. And so we have a particular incentive model where even a chief financial officer goes, we need to go get those HQIP dollars. It's $128 million in this bucket across all the hospitals, and we're going to spend every dime of it every year. So what did we do? We said, yes, we want to have a C-section measure. We want the Healthy People 2030 goal to be our floor. If you can't hit that goal now, you don't receive any points for this measure. Then we take everyone who is better than that and we tercide them. They compete against themselves. And so the ones who are performing at the very top get the highest amount of points for, the 5 points for this. And if you're in the middle tercile, you get 3 points. And if you're in the bottom tercile there, which you can see where this landed for 2023 for us. Dr. McClellan, you're still beating that. You're still, you're right here in the middle. You're in the 3-point bucket. Where our hospitals are landing. We have 11 hospitals that have a rate at 15.8% or lower. We have 10 hospitals that are between 15.9 and 20.9%. 11 hospitals that are between 21 and 23.6. But we still have 16 labor and delivery hospitals that are not meeting the Healthy People 2030 goal. They're not receiving any points until they get there. We have been asked, does this trend on rural or urban? You were just hitting on some of these things. It doesn't. This is a mixed bag in terms of the hospitals that are in each of these categories. We have large urban, small hospital, small rural, mix in each one of these terciles. We did do some research around this, and the best research we found was there is no correlation between urban or rural hospitals and their C-section rates. There is some trending geographically nationally. So hospitals in the Southeast United States have similar C-section rates to all hospitals in the Southeast, to the Northeast, to the West Coast, et cetera. The only correlation we were able to find, as Dr. McClellan was hinting at earlier, was higher C-section rates associated with for-profit hospitals. But I want you to look at this third bullet here. So, kind of the details of this are all hidden in here. Qualified births, NTSVs, you need a minimum of 30 births. So we're really throwing out those outliers, those really small hospitals that maybe have, 1 or 2 they're doing or transferring some out. These third and fourth bullets is what's really important for us. When we were thinking of this measure, okay, I have an outcomes measure. Where we've seen difficulty is the wrong word. Where I think there's been a gap in quality measurement has been, here is a number, I want you to hit it, and I don't care how. Numbers are manipulated. You can manipulate numbers all the time, and we see that happen. And those, in the absence of balancing measures and other things, we've seen where you can have some adverse impact in terms of just hitting a number, I don't care how. We saw it in nursing homes with hospitalizations. So what did we say we want to do here? We say, well, what else drives? And we looked at the research and said, yes, folks are human, and they are driven by perception, and they're driven by peers. And what we have seen in other studies and some other studies that were out there were that putting this competitive kind of nature or this sunshine on rates of individual physicians actually had more impact on C-section rates than financial incentives to an individual physician. Because again, they're not saying, ooh, I might make some more money if I go in here and do a C-section, right? But they will pay more attention on how they're comparing with their peers. So as part of this measure, just to get in here, before you can ever even get considered to whether you're going to get any points, every hospital has to describe a process for notifying each of their delivering physicians of their respective C-section rates and how those rates compare to other physicians individually and the hospital's average. So you're probably seeing that from Denver Health as a result of this program. And if you're working at a hospital, your physicians are seeing this as a result of this program. This wasn't happening in many cases before this. And it should be communicated to the physicians through a regular report, as well as through regular executive and team meetings. So it's getting all the way up to the top as well. Here's how we're performing. Here's the discrepancies between our physicians. We believe this is going to have just as much impact on physician behavior, if not more, than the financial piece. The financial piece is what gets the C-suite to say, go pay attention to this because we need these dollars. So we're trying to hit it both ways. Does that make sense? We're trying to hit that non-human organization and that financial incentive through a revenue maximization model, and hit the human component of physicians through regular reporting. This is what we think really makes this a valuable measure that you don't really see replicated in many other places. I don't know if I need to go through the calculation of the payment if you're kind of interested. Volume does play into here. You earn the amount of points you do for the program, and we pay it out a rate depending on where you score in the program. I'll talk about that in just a moment, per adjusted discharge point. So the number of points you score in the program times your adjusted discharges. So there's some volume that kind of impacts that. Just a little wonky stuff. Here's how it plays out though. We create a system. This was not the case. So when we first built this, we just kind of divided it out and paid by adjusted discharge. It was like, when I did the correlation on it, it was volume was driving payment more than performance in the program. So we changed it and said, nope, if you're between 20 and 39 points in the program, you get X. You're 40 to 59, you get 2X, 3X, 4X. So there's another incentive for the hospitals to do better across all of those measures to maximize their points, because you might have 10,000 adjusted discharges. 20 points times 10,000 is a whole lot different than 85 times 10,000. And with 4 times as much payment. That's a strong incentive for your C-suite to go, yes, please, Dr. McClellan, get your team. Let's go make sure we're doing better on C-sections. That balances it, because we do still pay more for C-sections than we do for vaginal deliveries on the fee-for-service side. So that's HQIP. Does that make sense there, folks? Does that help in how we're trying to hit that? Because I think that ties in a lot to those. What were the values and what we were trying to think about in terms of psychological impact, and how do we incentivize better behavior? I get a really cool job. I get to do that. I get to incentivize leading best practice. I want to spend a few seconds. This is not my wheelhouse, but Dr. McClellan also mentioned alternative payment methods and blended models. We do have one with Medicaid around births. It's a bundled payment for deliveries. It's a maternity bundle payment program. We really just take a retrospective look. We look at the hospitals, we look at the traditional cost associated with an episode, and an episode is including prenatal, labor and delivery, and postpartum care associated with the single delivery event. We look at a historical cost of that by a provider who's enrolled in the program, establish a threshold, and then going into the future, we look through the program year for any other episodes they have going forward. Were their costs less? And if the costs were less, we share in those savings with them. So there's an incentive there to, especially if you're a provider who's doing a whole lot of non-indicated C-sections, you have a lot of opportunity in this program to bring those down. You might get reimbursed less on one side, but you're going to get shared savings through this program to help incentivize that behavior. This program was very small. It's kind of in its 4th year now. Beginning in the spring, we are going to start to work on a new maternity bundle payment. So I'm going to have some information here for you to reach out if you want to be involved with that. If you have any providers that might be interested, you can certainly reach out there. I did ask them some questions. I was like, well, tell me a little bit more about this program in respect to vaginal versus cesarean delivery. So again, providers do not receive a directly related goal around C-sections in this program. I do that with HQIP. But they do break out vaginal versus cesarean separately in our calculations so that they can see how each of those categories played a part in determining those threshold goals. How much did this determine your historical cost? This is a complement, does not replace a provider's existing payment structure. The program is voluntary. And again, we're in our 4th year, but we are, our current participating providers account for roughly 30% of Medicaid births in Colorado. So it's not an insignificant amount of births, but we don't have a ton of providers in the program. Information on opportunities to design a new maternity alternative payment method is going to start here in early 2024. There's going to be a web page we're going to put out. We're building that right now, building out the program. So you probably haven't seen a lot about this yet. So it's hot off the presses for you all. If you want more information, please reach out to the email here or check out the website here for the current page. But reach out to Steve Harrington. He's a plethora of knowledge here. He's the lead for the program. If you're interested to learn more about our alternative payment method with the maternity bundle payment. But I'll pause there, and I think we should take some questions, Dr. McClellan. What do you think?
It's a great idea. Please, for
you, Matt.
Okay.
Stefka gets to ask me all her questions.
Through email in the past, but I think one of the things that I struggle with when we look at NTSB, cesarean, the different tertiles, one of the things that, and you're right, the C-suite is reaching out and they're knocking on my door saying, why is Denver Health C-section rate on 16%? Like, whoa, but let, wait up for a second. So, I know looking at national data, the variation by region is much more significant than by hospital type or size. With that being said, though, I doubt there's a single large volume, and I have to define it in a large volume delivery hospitals in Colorado is in those certified, right? Most of the hospitals are going to clear for them. And we know that the C-section rate is not even lower than certified. And I think part of the reason has to do with the patient population, right? As you were saying earlier, every rural population, every scout, right? You can have a patient with multiple comorbidities to whatever it is, being able to get on, they get surgery or transferred to the larger resources. So I guess my question is, how does that happen? At a state, at the state level, because I don't think it's realistic nowadays. My hospital, the other house, we have to
Thank you for the question. And for those online, the question is, I understand the H-QIP measure, looking at your tersiling. How does it account for case mix or acuity? And we do not risk adjust the measure. We do think that some of that is normalized in the fact that we are looking at NTSV using the measure specifications there. We're not looking at more high-risk bursts, because I think that some of that with Denver Health is also Children's Hospital is not in this measure, even though they do more than 30 bursts, because all of theirs are almost high risk. We don't have a really solid risk adjustment case acuity methodology nationally be able to apply here. But we do see this applied nationally across all types of hospitals. National measure, we don't risk adjust, but we do think that the NTSV does normalize that to some degree. No measure is perfect, unfortunately, but we can continue to discuss offline about opportunity there, opportunity for improvement or what you're all seeing, and I'm always open for a conversation. Please.
Thank you. I think there's some opportunity to consider that, because I think it could potentially be detrimental and penalize hospitals that do not transfer or accept those patients, right? Ultimately, patients end up somewhere. And also, as we know, many of the comorbidities, diabetes, hypertension, obesity, lack of resources, all of those things are associated with socioeconomic status, right? So we're talking about the insurance. So again, there are certain hospitals that can choose not to accept Medicaid, right? Or very little in their payer mix, and then there's cases that are very dependent on that. And there has to be some sort of a balance, I think.
Yeah, thank you for that. And we see a mixed bag across those terciles in terms of Medicaid volume type of hospitals, but Denver Health is certainly a special case. Dr. McClellan, please.
I'm going to add one thing, and this is to agree with Stefka and not to throw Matt under the bus, but because I do want to present with Matt again if we ever do this, because I really enjoyed it. But I think just to comment on NTSV as a way to kind of like smooth that out, NTSV is getting rid of sort of the less avoidable C-sections, right? It's getting away from your twins, your brief delivery. It's like those are the things that are less in control of people's hands, depending on the hospital they work in or their experience. So you can have an NTSB patient who's, young with a BMI of 25 and no medical comorbidities, or you can have someone who, like we see every day at Denver Health, with a BMI above 50, both diabetes, hypertension, a whole bunch of stuff kind of irritating their placenta and making it a lot less likely that that patient makes it to a vaginal birth. So I think the NTSB does, I think, not necessarily adjust for that in the same way.
Sure. And I appreciate that. And we certainly would want to be looking at some data Because some of that should be normalized across all of our populations, because again, that bucket I showed you was not, the only thing that's predetermined is the Healthy People 2030 goal. Everything else is a tertiling of the actual performance of all hospitals in the state. So we know we have also rural areas that have way more BMI than even urban areas and homeless populations, right? We have, but let's look at the data. I always say when we have questions, let's go to the data, see what it tells us. Other questions, please.
Bundle payment for the providers, is that like, can individual providers apply for that or groups apply for that? But if we as a hospital go and join HPIP and we want to show you how good we do in all these measures. But how does, I haven't seen that with the providers, and so I'm just curious, like, how do people get involved in that? And
Yeah, it's a great question. So that's kind of that other side, right? HPIP is that more organizational type of incentive approach where with the maternity bundle payment, it's actually obstetric care providers who are actually individually applying to be a part of that program. And those are those providers that are providing prenatal services, regardless of whether they actually deliver the baby, which I think is interesting in that. But again, this is kind of going to, it's almost been like a pilot. I think even though we have 30% of births recognized in that early pilot, it wasn't an active recruitment. I think there was some targeted early stage. I know Dr. McClellan, you worked on some of the early thinking through some of that, but I think from the lessons we've learned now, that's why they want to re-engage with stakeholders and start to think about how do we improve upon that and move forward in terms of a better maternity bundle moving forward. So look for more information here in April to be able to think about what comes next. Okay, we are at time. Any other questions? Thank you so much. Yeah.
Thank you both so much. Next, we would like to welcome up. Oh, I do have to exit out of the Zoom. I'm so sorry. We're going to miss you all. Thank you so much for coming.